This portion of CardioSource Video News is supported by the makers of Xarelto.
Welcome back to Day 3 coverage of ACC.12. I'm Dr. Andy Martin with CardioSource Video News, and we're talking about late-breaking clinical trials, and this is actually part 2 of a discussion we've had. Let me introduce our panelists. To my immediate left is Dr. Tony DeMaria, who all of you know. Tony's editor of the Journal of the American College of Cardiology and also professor of medicine at the University of California in San Diego. Dr. Deepak Bhatt. Deepak is associate professor of medicine at Harvard Medical School and chief of cardiology at the Boston VA Hospital, and Dr. Paul Douglas, who's Chief of Cardiology at the Atlanta Medical Center in Atlanta. So we're glad to have all of you here. Deepak, we're going to begin with you. Tell us a little bit about a trial called the Stampede trial.
Sure, happy to. The trial was led by a bariatric surgeon, Phil Schauer, and endocrinologist, Sangeeta Kashyap, some colleagues of mine back when I was at Cleveland Clinic. A single center study, 150 patients randomized to either bariatric surgery or medical therapy. These were patients, all of whom had diabetes that was not optimally controlled, who were additionally either obese or overweight, BMI range of 27 to 43. And in that population, the goal was to see whether bariatric surgery would be better than best medical therapy to treat diabetes. And for the primary endpoint at 12 months of essentially getting the hemoglobin A1C below 6, surgery beat medicines by a long stretch. Additionally, other biomarkers that were examined, things like insulin, HDL, triglycerides, hsCRP, all huge differences between the surgical arms, and there were 2 different types of bariatric surgery, and the medical arm. And I think, importantly, there was a significant reduction in the need and number of diabetes medicines, and for that matter, antihypertensive and antilipidemic medicines in the surgical arms versus the medical arms.
So, Tony?
So I guess, Deepak, that begs the question, if they lost weight without the surgery, would the same thing have happened? I was interested to see, looking at the data, that the change in biomarkers happened pretty quickly, probably before they lost weight. So there must be something going on with gastric hormones, I guess.
Yeah, you've got the sharp eye of an editor. You're absolutely correct. That wasn't actually explicitly pointed out in the presentation, but yes, that's true.
So it's non-weight related initially?
Well, at least part of it, because the effect kicks in too soon. The weight change occurs later. So there is probably something else going on, and it probably has to do with various gut hormones.
That's interesting. Paul, is this new data for us?
Well, you know, it's what the surgeons have been saying all along. It's nice
to have
for us, not for the surgeons. So it's nice to have some randomized clinical data to support what they've been saying, telling us all along. And I think that that you're right, that something else must be at play here, you know, because you see these metabolic changes so early after the surgery. So it's more than just the weight loss.
And Deepak, do we think these are going to last? These changes are going to last?
Well, I'm glad you asked. The primary endpoint was this 12-month biochemical endpoint, but there's a 4-year extension going on, so hopefully we'll have long-term data to report.
So does this change our practice with difficult to manage diabetics and who are overweight?
Well, you know, I really think it does. It's like the smoking issue. You know, if somebody came across with a treatment that would obviate smoking, it still wouldn't overcome the simple fact, stop smoking. And it's the same thing here. If this was just weight reduction, I'm not sure it would change as much as what we seem to be seeing, which is some hormonal change that weight reduction probably could not affect.
We're going to go ahead.
And Paul. Then the other thing I think is key is that this is a relatively short study, and the issue will be, will we see a reduction in cardiovascular outcomes and events down the road? I mean, will that make a difference? And I mean, hemoglobin A1C it's a nice surrogate marker, but are we going to reduce cardiovascular events?
Absolutely. Okay, we're gonna really turn to super intelligent Deepak here to tell us about the second trial, because we need your intelligence to explain this to us.
Sure. I don't know that I can explain it intelligently. It's a really clever trial in design, and by trial, it's a Mendelian randomization. So it's not the classic sort of you get drug A, you get drug B. Because with genes and mutations, of course, we aren't in a position to randomize, right? That requires a higher power. So what is going on here is that the investigators have looked at different genotypes, SNPs, mutations, that are associated with various levels of LDL cholesterol, and seen what impact those different genes and mutations have on LDL cholesterol levels, and therefore might have on cardiovascular events. And what they found, I think, is intuitive, but really quite elegant, that is lower LDL cholesterol levels are associated with lower levels of risk, and the earlier that LDL cholesterol level is low, the longer that it's low, the better. So, and that seemed to be true irrespective of the mutation that led to that particular level of LDL cholesterol.
So it doesn't matter how you got there, mutation-wise.
So at least in the natural experiment, it doesn't seem to matter how you get there in terms of your low LDL cholesterol. Can we extrapolate that to diet and exercise? I'd say, yeah, almost certainly. Can we extrapolate to medicines, statins? I think so. Other types of medicines? Maybe.
It's interesting because the pediatric literature is replete with this thing of should we be treating kids early. So Tony, I'm sorry.
No, it's red hot in light of the recent FDA warning that statins can be associated with a number of adverse effects, and some prominent cardiologists have come out and said we really should not be doing statins for primary prevention, and this would be the equivalent of primary prevention if you're born with the mutation. And the key issue is whether statins are truly identical in their action.
Yeah, it's interesting. Paul, thoughts on this?
Well, I mean, again, I think this helps us to identify people at greater risk, and the earlier we do that, the better off, hopefully, they will be. And so, I mean, this was an eloquent trial, and it's going to be, I think, a huge contribution to our management in dealing with childhood obesity and those kinds of things.
You're exactly right. I'm sorry for interrupting you. So as a final thought, Deepak, do you have a feel that that we have any information from the genetic trials that would say that statins are an equivalency of...
Sure, so this study can't address that at all, but I think Tony's right. It does indirectly support that primary prevention should work. Will it justify being on a statin for 5 decades, potential side effects? Can't say from this study, but it does lend indirect support to starting early and starting aggressively in terms of LDL cholesterol reduction.
And Paul, that goes along with what you've been preaching for so long in the community of really primary risk reduction. Okay, well, thank you all for joining us. You did a great job, educated me, and I'm sure you educated all of you. And we hope that you'll join us for more at ACC 12.